Good afternoon to everybody out there. Thanks for coming. I was actually quite looking forward to giving a presentation today because I think the research program is about to make a very important step forward. So I thought while I tell you what we're doing, I can acknowledge some of my collaborators and also members of the team. And what we're really all about is asthma, and asthma is a highly prevalent condition. It's also costly to treat. These numbers here may seem small compared with the amount of money that's gone out the door with the pandemic, but it's important to appreciate that asthma is a disease of a lifetime for most patients. So this deficit here accumulates. I do feel like there might be a bit of a misconception with asthma that it's not a serious condition, and that might be true for some patients that have bothersome symptoms, but it can get very serious, and there's 250,000 deaths each year. It's argued that many of them might actually be preventable. I do like the Jane Pillow group where they put in a very cute infant and then introduce preterm birth. So along the same lines, this is poor old Chris. Chris has been hospitalised as a result of his asthma. He's very scared, he's struggling to breathe, and he's saying he's going to die. And the reason he's struggling to breathe is because of constriction of his airway passages, viewed by a bronchoscope here, and clogging up the airways with a mucus. So this increases the resistance to airflow and just the work required to breathe. It is treatable. He's been administered an inhaled bronchodilator there, but you've got to question the logic because the airways have constricted. So how do you get this agonist to the regions of the lung where it is required? So they're working on a plan B. They're going to access the venous circulation and eventually administer a systemic bronchodilator, and that should be able to dilate or relax the airway smooth muscle through the bronchial circulation. Point of this slide is that asthma is a serious condition. Here is the pathway to disaster. It all begins with some type of trigger that's inhaled into the lung. Allergic asthma is the most common form of asthma, be it pet dander or pollens or dust mites. What's probably missing from this schematic is exercise-induced asthma. This trigger will induce an inflammatory response, activation of inflammatory cells or infiltration of inflammatory cells into the airway wall. Inflammation drives contraction of the airway smooth muscle cells that line the airway, and contraction of the muscle causes narrowing of the airway lumen. And due to this narrowing of the airway lumen, there is an increased resistance to airflow, and essentially breathing becomes more difficult. And all of these symptoms here are just telling us that breathing is hard. You wheeze, there's chest tightness, there's cough, and you could call hospitalisation a very serious symptom, and there are indeed fatal asthma exacerbations. That figure or that slide really only told half the tale. In subjects with asthma, the airways have an increased capacity to narrow. So if an individual who doesn't have asthma breathes in a trigger that contracts the muscle, the level of airway narrowing that's reached isn't all that serious. It may not even induce any type of symptom. But in an asthmatic patient, the level of airway narrowing becomes quite critical. Some of my own data here. So we have airway segments were studied in an organ bath chamber. We got these airway segments from subjects that were undergoing lung resection surgery to treat their cancer. So these airways would have gone to waste. We measured airway narrowing capacity from the percent reduction in lumen volume. It could have been radius or cross-sectional area. And we stimulated the muscle to acetylcholine. Quite clearly in the asthma group, the capacity of these airways to narrow was increased. and this is just a mild asthmatic group. The level of airway narrowing is increased in moderate asthma and even more severe asthma. This condition is clinically referred to as airway hyperresponsiveness, and we believe that it's due to an intrinsic capacity of the airways to just slam shut. If you're looking for the underlying mechanism, then a good place to start is airway remodelling. Here we have a histological image. This is half an airway from an asthmatic subject compared with a non-asthmatic subject. This is the airway wall. The airway wall thickness is increased in asthma, and there's various abnormalities that are observable. Increased thickness of this basement membrane. It's not even observable in the normal airway. A bit of mucus there. The epithelium is dysfunctional in asthma. There's a lot of good epithelial scientists in WA. If any of them are listening, it's a very important cell type and one that I will pretty much ignore today. I'm more focused on this airway smooth muscle. In asthma, the airway smooth muscle is expanded and probably contributes a lot to the severity of the disease. And there's no one throughout the world that really has done more to outline the role of the airway smooth muscle remodelling in asthma than Alan James, clinical professor Alan James, across the road at Sir Charles Gairdner Hospital, and his long-term scientist, John Elliott. John Elliott is now a FIFO histologist. He's going to be spending half his time in Melbourne. Some very important colleagues here. This study was done in 1993 at Sir Charles Gairdner Hospital. We have three groups. Essentially what happened is they acquired some airway tissue at post-mortem from subjects that had died directly of their asthma from a control group, and subjects that had asthma but died of another cause. In histological sections, the area of the airway smooth muscle was measured. On the x-axis, we have the epithelial basement membrane perimeter. This is a standard index of airway size, so you'll see me use this quite a bit today. All it's really telling us is that we're going from small airways to larger and larger airways. The graphic demonstrates that there is more muscle in the fatal asthmatic compared to the non-fatal asthmatic, and both of them are greater than the control group. And we see this remodelling throughout the bronchial tree. And I really think that this paper emphasises how important airway smooth muscle remodelling is to severity of disease, particularly because it's increased in these fatal cases. Over the years, further studies have been performed to try and understand what causes the expansion of the airway smooth muscle area. And it has been attributed to an increased size of the cells, hypertrophy, and also an increased number of those airway smooth muscle cells, so hyperplasia. Throughout this presentation, I might refer to some mathematical modelling, and these earlier mathematical models really showed you exactly how important airway smooth muscle remodelling was to functional impairment in asthma. Using a human model of lung function, you can predict airway resistance to a theoretical dose of agonist. So this might be increasing doses of acetylcholine. If you expand the area of the smooth muscle layer, you get substantial increases in airway resistance. And if you simulate other changes like gross wall remodelling, you don't get the same effect. So really, the critical change seems to be airway smooth muscle remodelling, and this is the reason that I focus on this particular pathology. How do we treat asthma? Well, we do a few things. First of all, we inhale bronchodilators to reverse muscle tone, to relax the airway and open them up. We have short-term reliever bronchodilators and also long-term acting bronchodilators. You don't really want to wait for the airways to slam shut before you administer it, so long-acting bronchodilators make sense. We do very well at treating inflammation. Inhaled corticosteroids is a broad spectrum approach with some side effects, and if things get very bad, then we move on to oral corticosteroids. Special mention to monoclonal antibodies. My clinical collaborators really tell me how useful they are in treating the disease. Monoclonal antibodies essentially target very specific aspects of the allergic cascade. And this is the result of science. We can now treat inflammation in a much more sophisticated way. Now, what do we do about airway smooth muscle remodeling? That's the question that we'll discuss now. It does depend on how you think. If you agree or believe in the conventional hypothesis that inflammation causes airway smooth muscle remodeling, then you think we do a lot because we put them on anti-inflammatories, so that should resolve airway smooth muscle remodeling. However, this conventional hypothesis is really being brought into question, and I'm going to show you some data to support that statement. I guess the logic behind the conventional hypothesis is that the most common form of asthma is allergic asthma, and if we make animals allergic and expose them to this allergen, they can develop smooth muscle remodeling under the right circumstances. And this is a study here. Mice were made allergic and exposed to house dust mite, and the number of cells per basement membrane perimeter. So again, this is just standardizing for size. I'll use it again. You can see that in response to this exposure, there's a gradual increase in airway smooth muscle mass, which certainly supports this conventional hypothesis. The problem is, as I see it, is that just because you can demonstrate airway smooth muscle remodeling in this manner, in a highly contrived animal simulation, does not necessarily mean that is the way it occurs in human asthma. And there are numerous different pathways to this same outcome. Enter Kimberly Wang. Kimberly Wang is, as you would know, a very, very hard-working research fellow in the department. We've been working together for many years, but who's counting? And Kimberly does a lot to push us all along. Now, Kim came from a cardiovascular lab where she was looking at the effects of fetal growth restriction on cardiac dysfunction. And when she came to shift to the respiratory field, she also noted an association between asthma and fetal growth restriction. So she wondered, well, what does fetal growth restriction do to the airway smooth muscle layer? Set about making an animal model of fetal growth restriction. And here's some data here. We have body weight versus airway smooth muscle thickness. And you can see an inverse relationship between body weight and airway smooth muscle thickness. So the overall body size seems to be growth restricted, but the airway smooth muscle is expanding in a disproportionate manner. So the airway smooth muscle is thickening. So you can see in this study, we've thought about things a bit differently. We don't care about allergy in asthma. We think, okay, growth restriction in asthma, and we're able to thicken the muscle using a non-allergic pathway. Another study here, transgenic mice, don't recommend working with them. Essentially, they were triggered to express a growth factor, transforming growth factor alpha, and after this growth factor was expressed within the epithelium, the airway smooth muscle expanded. And in this model, expansion of the airway smooth muscle layer was totally independent of inflammation. So both these studies here show that the airway smooth muscle can remodel through pathways that are totally independent of allergy. And in fact, we proposed an alternative hypothesis. Maybe you need remodeling through, maybe it's a developmental disorder. That's Kim's career hypothesis. Maybe it's through some other mechanism. If you have remodeling and you also are unlucky enough to develop some type of inflammatory disease, then you are finally diagnosed with asthma. Now, before I move on from this concept and explain why I'm talking about it, let's have a look at some of the evidence from clinical samples. 4 studies here. Airway smooth muscle thickness is increased in children with asthma even before diagnosis. So this shows you that airway smooth muscle remodeling is present early in the clinical course of the disease, which would fit well with a developmental origin of airway through muscle remodeling. In fact, it supports the second hypothesis there because we're observing it before diagnosis. In a systematic review of childhood asthma, there was no occasions where inflammation was detected prior to airway through muscle remodeling. So if inflammation is supposed to cause airway through muscle remodeling, shouldn't we be able to see it before the remodeling? It doesn't seem to be the case, certainly from this systematic review. Some more data here. Increased thickness of the airway through muscle layer is demonstrated in adult cases of porphyria granulocytic asthma. So essentially, if there are no inflammatory cells, you still see airway through muscle remodeling. On its own, probably not strong evidence, but it certainly does support this inflammatory independent origin of muscle remodeling. And finally, there's no effect of age or duration of asthma on airway through muscle thickness. That is, airway through muscle thickness is constant through adult life. If you think about asthma being a disease of lifetime, it's going to be impossible to avoid the allergen altogether. So presumably we get frequent inflammatory episodes. So if inflammation is the cause, shouldn't we see a gradual increase in airway through muscle thickness? Much like that study where I showed you where as the duration of house dust mite exposure increases, we got a gradual increase in airway through muscle thickness, but that doesn't seem to be the case. So the point that I'm trying to make is that there must be reasonable doubt on the conventional hypothesis that inflammation causes airway through muscle remodeling. Therefore, there must be reasonable doubt that anti-inflammatory therapy will be sufficient for the resolution of airway through muscle remodeling. I think we need an alternative way of treating this airway through muscle remodeling. Bronchial thermoplasty. So bronchial thermoplasty is a talk that I gave a couple of years ago, so I'm not going to spend too much time on it today. I like it though because it directly targets airway through muscle remodeling. Patients are anaesthetised and a bronchoscope goes into the airway. A probe comes out and it heats up to about 60 degrees. And from lack of a better way of explaining it, essentially burns the airway through muscle layer away. It's quite invasive. 3 different anaesthetic procedures are required. Number 1 treats the right lower lobe. 1 month later, another anaesthetisation procedure treats the left lower lobe. And then another month later, the third procedure treats both upper lobes. Does it work? If the goal is to remove muscle, it does. Here's some bronchial biopsies. You go in there and you scrape a small region of the airway. It doesn't seem to be a great way of measuring muscle because you're only getting a small portion of the circumference of the airway at a very localized region. However, the data is quite convincing. Here we have before bronchial thermoplasty, the muscle here. And after bronchial thermoplasty, it looks like all the muscle's gone away. And from all the quantitative studies that have been performed, this is just an example of the basket that goes into the airway. 75% reduction in airway through muscle area is actually a very constant number. So there's big decreases in airway through muscle area. How about the patient? Do they feel better? Well, I think they do. I need to acknowledge David Langton. He is the guru of bronchial thermoplasty in Australia, probably the world. I'm biased because David is just such a great guy, and I've been lucky enough that he's involved me in his work with bronchial thermoplasty. On the y-axis here, we have the asthma control questionnaire score. So if your number goes down, your patient feels better. After a bronchial thermoplasty, there was a clear improvement in asthma control, well above the clinically meaningful change of 0.5. So patients feel better. In terms of physiological improvement, there's more and more data supporting real benefits of bronchial thermoplasty. Here, airway volume measured on computed tomography. After bronchial thermoplasty, airway volume goes up. this means the airways are dilating. So we're removing that muscle that's causing contraction of the airway lumen, and we get bronchodilation. So bronchial thermoplasty is working. However, it's a controversial technology because of this pro-con debate. Let's start with the pro. There's a potential improvement in respiratory health at 10 years after treatment. So this is, really very strong evidence that bronchial thermoplasty is worth investment, because the patients still feel better 10 years after treatment. There's no evidence that the airway smooth muscle grows back. That's a 3-year time point. This is a treatment approach that is independent on the mechanism producing airway smooth muscle remodeling. It doesn't care if the remodeling is produced by inflammation or not. It just goes straight there and burns the muscle away. It's cost effective. If you are having improvement in asthma control, then you have reduced reliance on medication over that period and reduced hospitalisation. So bronchial thermoplasty, even though it's expensive to begin with all these anaesthetic procedures, it does prove to be a cost-effective modality. There's a lot of negatives. It's invasive, three anaesthetic procedures. You're only treating a few relatively large airways, about 20 airways that you can reach with this basket you treat. And we don't even know if those airways are remodeled or not. We might actually be treating relatively healthy airways. There's skepticism, since the conventional measures of lung function do not change, and I'm talking about the forced expiratory volume in 1 second for those of you who are familiar, and there are placebo effects associated with bronchial thermoplasty. For some reason, if you just perform an anaesthetic procedure, the patients feel better, so that's the placebo effect. We're unclear which patients that should be selected, and there are post-procedural side effects. So if you're able to target airway smooth muscle remodeling and overcome some of those cons, you might go down that pathway. So what about pharmacological targeting of the airway smooth muscle layer? A non-invasive alternative to bronchial thermoplasty. I think we need to use a drug that does not necessarily rely on inflammatory pathways, and I hope you appreciate why I think that's necessary. Maybe we need to modify the proliferative and apoptotic state of the airway smooth muscle layer. So let's talk about that. Funny enough, azithromycin might actually be a pretty good place to start. We'll be able to treat both small and large airways if we use a pharmacological approach, not just airways that we can reach with a relatively bulky tool. So that's an advantage. Talk about that. And also, I just want to comment why this approach, which seems quite intuitive, has not been advanced previously. It's been stagnant due to limited ability to quantify the airway smooth muscle layer until now. So we'll talk about that. Okay, so this is sort of data that has been around in the field for quite some time. This is a relatively recent study, this one. I've never really thought about it too much until now. It's a fact that the airway smooth muscle layer is under a constant state of proliferation and also apoptosis. In histological sections, the number of proliferating cells were assessed by pCNA in control subjects and asthmatic subjects. The point I want to make is that even in the control airway, the smooth muscle is proliferating. Some would argue it proliferates more in asthmatic individuals. That's a common hypothesis. This study here doesn't seem to show that in a in situ environment. We've looked at it too. Also didn't see any increase in asthma, but both are proliferating. There's also ongoing apoptosis using the tunnel assay. So both of these are immunohistochemistry. Now, I'm not an expert in this, but this is essentially how they assess these type of behaviours. There's also ongoing apoptosis in the control airway and again in the asthmatic individuals, but doesn't seem to be any difference between these groups. So if you have ongoing apoptosis and proliferation which seems to favour thickening of the muscle, and apoptosis which seems to favour thinning of the muscle, maybe a really good therapy would be to reduce proliferation or increase apoptosis. Is this a good place to start if you're looking for a very specific or direct drug to treat airway smooth muscle remodeling? Azithromycin might be that drug. It's certainly an interesting drug. Kimberly actually decided this was a good place to start because she wanted a drug that could take away airway smooth muscle from the normal airway, so we could start to understand exactly what airway smooth muscle does in normal airways. We know it gives you asthma, but what is the real function in the healthy airway? Azithromycin is a macrolide. It has antimicrobial functions, anti-inflammatory functions, anti-mucin producing functions. There's not a lot that these macrolides seem to tolerate. In the MAZES trial for asthma, 3 doses per week were administered orally for about 48 weeks. This reduced exacerbations of asthma and improved quality of life. So it does seem to be another treatment modality for asthmatic patients. We wondered, what is the effect on airway smooth muscle remodelling? These are data in culture. We have percent proliferation using some assay, optical density assay, doesn't really matter. Proliferation goes up as we go up the scale. Azithromycin was administered to, I think these are rabbit airway smooth muscle cells for about 3 days. There's a couple of control groups there, but this is the control group that matters. And this is increasing concentrations of azithromycin, and you can see a gradual decrease in airway smooth muscle proliferation. So there seems to be stage 1 evidence that azithromycin could help us in thinning the airway smooth muscle. What about level 2 evidence? In collaboration with my good mate Alex Larkin from Telethon Kids Institute and the great Peter Henry from Pharmacology, who's just retired, we had a look at the effects of azithromycin in a mouse model, so an in vivo mouse model, and these mice were either naive or they were made allergic to house dust mice. Airway smooth muscle thickness was assessed in histological sections. And after only about 10 days of treatment, there was a reduction in airway smooth muscle thickness with azithromycin, whether they were naive or whether they were allergic. So the drug seems to be acting through pathways that are not necessarily dependent on allergic inflammation. And overall, there was a reasonably chunky decrease in airway smooth muscle area, around 30%. But you could see that this is actually less than what is achieved with bronchial thermoplasty. So what we wanted to do was address the question that, okay, so we get this 30% reduction with a drug that probably is treating many airways throughout the bronchial tree, but you have bronchial thermoplasty, which treats a relatively few number of airways, about 20, but you get a lot, basically doubling the effect in these airways, about a 75% reduction. So we wanted to know which is the better therapy. So using some mathematical modelling, so Graham Donovan, a long-term collaborator now from New Zealand, hopefully he'll come and visit our department soon, basically perform these simulations using, again, it's a human lung simulation, and we're just simulating changes to the muscle layer. This is the untreated case here in response to increasing doses of agonist, and this is a log scale here. The red line is bronchial thermoplasty. To demonstrate an effective therapy, we want a lower plateau and also a rightward shift in the curve. So bronchial thermoplasty certainly does work, and some of the modelling predictions have actually been confirmed in patients, which somewhat validates the model. But the reason that I'm showing you these data is if you have a look at azithromycin, even though you're only producing half the decrease in muscle thickness, it seems to be producing a greater effect than bronchial thermoplasty, even lower plateau, and we're getting even more rightward shifted. So I would say that a pharmacological ablation of the airway smooth muscle layer is a very promising therapy. So why, this is the other question I wanted to address, is why haven't we thought about this sooner? And it really has to do with the fact that it has been very difficult to image the airway smooth muscle layer, and therefore we can't really test whether drugs are knocking down the airway smooth muscle layer. Biopsy is limited, and I don't think you should be causing continuous injury to the airways in patients or in a clinical trial scenario. So I don't think this is the way to go. MRI doesn't measure your muscle. Computer tomography will measure the thickness of the airway wall, but cannot resolve the airway through muscle. Ultrasound, there's horses with heaves, like kind of like an asthmatic horse. They argue that EBUS, endobronchial ultrasound, can actually image the muscle layer. I'm not convinced, certainly probably below the resolution required. But bronchoscopy itself is important because bronchoscopy is our access to the airway. It's going to allow us to get our probes into the airway so that we can then measure the airway through muscle layer. And the technique we want to use is optical coherence tomography. Can it measure the muscle? It's a yes/no because this basic form cannot, but the one we use can. So I'm going to talk about that. Also going to play a video here. This was from my PhD. It shows you how far we've come with image resolution. It doesn't look like a very good image there. This is a bronchoscope in a pig. And we've stimulated parasympathetic nerve stimulation there to cause muscle contraction. And we've got these ball bearings in there. So it doesn't matter if I move my bronchoscope, as long as I have access to that ball bearing, I'm able to have a look at relative airway size. So I could technically measure diameter of these airways with a little bit of imagination, but it was actually quite effective back then. True story, I couldn't actually buy ball bearings off the shelf, so I had to break into the stationery cabinet and actually get my ball bearings out of ballpoint pens, which is quite messy. So bronchoscopy will be important because it'll get our optical coherence tomography probe into the airway lumen. And here's some very old data, but we could already see the potential of this approach. So think about OCT as an equivalent to ultrasound, except you're using light waves. You get a reflection, so a one-dimensional distance from the reflection of a light wave. And then by rotating the probe head, you can then start to draw two-dimensional images, and it rotates a hell of a lot faster at around 30 hertz. And we get these type of images, and this is a low-resolution probe. But you can see there's some subsurface information already. We cannot distinguish the muscle, but as someone who also studied cartilage during their PhD, I just absolutely love this because I could see what the cartilage was doing during activation of the airway through muscle layer. So during my PhD, I would have to get a histological image of a relaxed airway and one that was contracted to a drug, and then I see how the cartilage is performed in different airways. Here, I could actually see that the cartilage plates were sliding underneath each other. It was telling me how the airways narrow, because if these cartilage plates were just a bunt, then it would wedge it open and you probably wouldn't get too much narrowing. But this provided some type of dynamic morphology as we described in the paper. So this was pretty cool stuff back then, but I don't think it's as cool as this here. All right, so this is in collaboration with David Langton in Melbourne. We decided let's start with some commercially available probes. Abbott probes for cardiovascular research, or so cardiovascular medicine. You can insert them into the bloodstream, and therefore we thought it's pretty safe to repurpose them into the lung, which it tends to be less sterile than the bloodstream. So David, in some severe asthmatics, tested out these probes. These probes are not appropriate for our use. We've given up on them, also because they cost $2.5 grand each use. So we're going to use our own probes. But we did get this nice little video here. So an airway, this is an image of a single airway in a single location. The cross-sectional area, cross-sectional view, and this is the longitudinal view. And these little blips here is basically motion artifact as the patient breathes. I want to focus on this structure here. You've probably already worked out what that structure is with the histologist in the audience. Something's going to happen very soon. The video is going longer than I thought. Something will happen, and there we've got some gunk that's come into the airway lumen, and you can hear the excitement in my voice because what we've just witnessed is the real-time release of mucus from a submucosal gland. That is dynamic morphology. Think of the power of this approach, and you won't see anything more interesting today, I give you. Okay, so using a standard optical coherence tomography, you cannot measure the smooth muscle layer, but you can using polarization sensitive optical coherence tomography. So I'm going to call that PSOCT from now on, if that's okay. Shout out to Michael Hackman. He's a German physicist who moved to WA. He's now doing a PhD with us. Top bloke, very precise researcher, and we're absolutely reliant on him because Alan, James and I, who are trying to make this technique into the clinic, believe it or not, we do not know how to build these probes. So Mike is doing this all himself and he's succeeding. So you'll hear him present on this area, but I will show you a little bit of data here. Using conventional OCT, you cannot see the muscle. That is actually probably the muscle, but without the matching histology, you just cannot be certain. The good news is that with the reflected light waves, we get a little bit more information that tells us that this structure here is highly organized, and this structure here is orientated a little bit differently from this blue structure here. In fact, it's perpendicular to this blue structure. And because we know the smooth muscle is an organized structure, and because we know it's orientated circumferentially, we believe that this is actually smooth muscle. And we can test that out by comparison with histology, which I'll show you soon. This is just an image of the airway smooth muscle layer. I just should say that we will eventually perform bronchoscopy to get these probes into the lung. And we're not going to just do a biopsy. We're going to rotate it at a single transverse plane, and then we're going to move the probe along the length of the airway. So you're getting several millimeters worth of data and the full transverse plane. So you're really increasing the amount of information to tell you whether an airway is remodeled or not. And this is just an image where we're pulling back the probe along the length of the airway. So you'll see that a bit of lumen will open up here. So, and the muscle thickness is gradually changing. And this final image is actually an overlay of these two images here, which Mike was the first to really question, can we actually get better resolution of the muscle if we consider both organisation and orientation at the same time? It may not be life changing, but under some circumstances, this approach could be the way to go. And I hope I haven't misquoted you, Mike. Okay, so does it actually delineate the airway smooth muscle layer? Absolutely. Here we have histologist versus engineer. It's not a contest, it's a comparison. Need to acknowledge my long-term friend and colleague, Alvinia. She runs our human airway tissue collection program. She does all our ethics. Unfortunately for her, our governance, and is also our expert histologist. And here you can see that when Alvinia measures the muscle in blinded sections, it compares very favourably to PSOCT determined airway smooth muscle area. So this is pretty convincing data, and I think we're ready to go into patients. I did have some third years from Pete Marks' unit do these as well, these type of measurements. We didn't get quite as good correlations with the third year students, but they commented that they struggled to actually measure the histology, whereas the PSOCT was probably an easier measure. And that makes sense because it's just about colour once you know which way the muscle's running with, whereas the histology, it takes a little bit more skill. We used cryo-embedded sections because we didn't want to cause any shrinkage when comparing our in situ measure to the processed airway. So we have a human subject that will be ready to go within weeks. We probably should have started about 1.5 years ago, but these things take time. We have our ethics, we have our governance. We didn't even know we needed a probe sterilisation certificate, but we've got that now, $5,000 later, whatever. We're just ready to go in vivo. We've performed a protocol simulation. This is Siobhan Mulrennan, who will perform the first PSOCT measurements in patients for us. We borrowed all this equipment from Olympus because this is exactly what we'll use in the clinic. And this is an ex vivo pig lung. We're looking into the ex vivo pig lung using these beautiful high quality bronchoscope bronchoscopy images, much better than the ones that I used during my PhD. We're going to go in there and we're going to find an airway that we feel is ready to image. And then you eventually see our probe go down a bronchoscope challenge. So hopefully you can now visualize exactly how this is done. The probe will soon be coming out the airway lumen, getting a bit impatient. It's going to come out there soon, probably. There it is. So we direct our probe. It's probably gone a little bit too far in there, and we're going to get it into our region of interest, and then we'll start the PSOCT scans. Okay, so almost at the end now. I should mention that PSOCT might be useful for other tissue types as well. We published a study called Fatty Airways Implications for Obstructive Disease, where we saw fat within the airway wall. It wasn't something that was really thought about in the asthma field before. This is a bit of fat in a pig airway. Carolyn Wang, hardworking PhD student who's generating a lot of data, basically advancing the hypothesis that fatty airways may be very important in the asthma field, and is just about to resubmit a comprehensive review where she commented that maybe OCT will be a way to measure it in vivo. And Mike, hearing about this, decided, okay, let's compare fat in the airway with that measured by PSOCT. This is a different modality of PSOCT, but these are essentially fat deposits. And this is very, very preliminary data that they've submitted for our grant, but there may be pretty good agreement. Okay, so what next? So ultimately what we're trying to do is develop PSOCT as a diagnostic tool for quantification of airway smooth muscle thickness that can guide therapy. Should we put them on bronchial thermoplasty if there's a lot in their large airways? And also test pharmaceuticals in a clinical trial scenario. We're going to measure airway smooth muscle thickness in patients with and without asthma. Hopefully that begins in a few weeks. Then after we've got a bit of preliminary data there, we'll shift our second system to Melbourne, and we're going to measure airway smooth muscle thickness in patients before and after bronchial thermoplasty. So David Langton's ready to go there with our custom-made probes. And just spend a little last few minutes on these last 2 points. We want to establish an in vitro drug testing model for airway smooth muscle ablation. This is a new NHMRC grant, which is a lot of fun to write. So Kim and I have spent some time on that. And then we will test the efficacy of agents in a preclinical sheep model and whether these changes elicited are long lasting. So let's touch on these 2 aspects now. A bit of in vitro drug testing model. We're going to use mechanobiology. I don't know if you know, but the department's been overridden by mechanobiologists. So that's going to happen if you let it. But certainly working with Yusok Choi is a lot of fun. And we're very lucky to have you and our PhD student, Joe, who's generated these data. So the whole idea of mechanobiology and use model is that we have a typical culture environment for our cells, and we've finally moved on to the key cell, the airway smooth muscle cell. And in this hydrogel gradient, the cells are cultured on progressively stiffer gels from relatively soft to airway smooth muscle cell growth. So this is cell size, and Joe shows that in proportion to the stiffness of the gel, cells start to increase in size and probably in number. It's just we haven't actually started to quantify that yet. So we want to use a model like this because it's important that we improve our translational capacity for any drugs that we identify in vitro, and that can be always a barrier to clinical impact. Looking at these data, we wondered, how does this actually impact our choice of drug? And it's interesting that at the soft end of the gel, this is a stiffness that actually is very similar to what you might expect in small peripheral airways, whereas the other end of the gel is actually closer to what you might expect in larger airways. So we thought that using gel stiffness, we might be able to tell if a drug can work on small, large airways or both. So picture this, we have on the y-axis cell number or size and our stiffness. We have our untreated line there, which is just Joe's data. If we have a green line and we add a drug, maybe this would indicate that our drug will only knock down growth in larger airways. Whereas the red line, maybe we got separation down here. Is it affecting growth of in the smaller airways, in the softer, smaller airways? Ideally, do we want this blue line? We're affecting essentially cells irrespective of their mechanical environment. So I kind of like that model that you and Joe have. Finally, in terms of the in vivo model, this will take a bit of time. We'll establish a sheep model of allergic disease, and to be honest, it doesn't even matter if the house dust mite produces airway through muscle remodeling. We just want to induce allergic inflammation to see if any drugs that we use are dependent on the inflammatory cascade or not. So two groups of mice, that will be sheep, that will be either untreated. There will be a positive control, so we'll be performing bronchial thermoplasty on these animals because we know that'll knock down the muscle. And then we'll have our test drug. It takes about 6 months to get the animals allergic. And then we'll put them on a drug for about 12 months. And at each of these locations, we'll anesthetize the sheep and do some PSOCT. We're going to get longitudinal data on airway smooth muscle thickness. I don't think that's ever been done before, so really excited about that. Eventually, we'll take them off the drug and then see whether the changes in response to the drug actually persist for a further 6 months. So does the anti-remodeling effect stick around is the idea there. And lastly, not least, I haven't mentioned James Wong yet. He doesn't work in asthma, but he does. He's the only person working in airways in kangaroos. And he published this paper that's about to come out. Does Skippy wheeze? Evidence of airway remodeling in the Australian kangaroo. So he'll be telling you about this at some stage. There's a really, really thick basement membrane in these kangaroos, as well as eosinophilic inflammation, which is quite interesting. So it's not muscle remodeling, but it's a different form of remodeling. And we wonder, is this another innate model of asthma? So a lot of hard work involved in this study, James. So well done, mate. Okay, so thank you very much for allowing me to speak today. 5 minutes late. I think I've acknowledged all my collaborators. There's a hell of a lot more people here that I just want to thank, and probably special mention to Barry Sense, who's my optical engineer in South Korea, very supportive of everything we're doing. And Xingyong Li, he builds the OCT systems. During the pandemic, he didn't care about the pandemic. He just wanted to build PSOCT systems. Another really great contributor. And of course, the lab, hashtag Airway Physiological Research Laboratory. If I've got the hash there, that automatically goes to Twitter. That's the way it works, isn't it? So I think that'll be me for today. Thanks, Shane.
Thanks, Pete. It's no wonder you look tired all the time. You've got a hell of a lot of stuff going on there. That's incredible. I mean, yeah, I've got a few things that I want to talk to you about, even if it's not now. But the first thing we'll do is see if anybody else has got any questions to ask. How do you know if somebody's got their hand up? I'm new at this.
There's a people. Silvana's got a hand up. Yeah.
Yeah, no, go Silvana.
Thanks, Pete. That was really fantastic. Really great stuff. Just in relation to the fetal restriction model that developing, and Kimberly's online as well, I guess. Is it possible that that is inducing epigenetic changes that then results in some immunological dysfunction that actually creates the sort of the impetus for the later disease later in life?
Yeah, that sounds perfectly feasible to me. If Kim, you want to jump in, go ahead. I guess for me, it was of interest because you could see, in a very short period of time, although in a mouse, I guess it's not, it's the full gestation for a mouse, or 2/3 of the gestation. So I guess that is a long time. You can actually see changes in airway through muscle remodeling in utero. The question is whether they actually persist throughout our life, or does the muscle mass stay the same and the airway sort of expands, so actually the relative thickness stays the same. But I buy your hypothesis too, Silvana. Kim, have I said anything silly there? Do you want to comment?
No, I agree. It's just something we haven't looked at, Silvana, the molecular side of things. We have been focusing on the structure function. But yeah, I have a lot of frozen lungs in the freezer. Yeah, so it's something, I guess, that we can look at it. Just haven't gotten around.
Thanks, Silvana. So while we're seeing if somebody else gets their notes together, won't it be terrific if you find out that this pharmaceutical approach, so the azithromycin, is knocking small airways, and you can get the large airways with the thermoplasty? So at the risk of telling you to do more work in your sheep trial, should you be doing a combination?
Oh, right. So we do a bronchial thermoplasty, yeah. Yeah.
Because I mean, with this stuff you're doing with Mike, you'll be able to tell people, is it the small airways? I mean, how far can Mike's probe get down? Can it get down into quite small airways?
Yeah, so we've published a paper about exactly how much of the lung that you can assess using this approach. So it's probably not Mike's probe that's to blame so much, because it's about a 1 millimetre size. So technically you could wedge it into a small airway. Yeah. It's the bronchoscope size that actually tends to limit exactly where you can get to in the lung. And even more so, let's say you want to image the same airway under multiple longitudinal time points. If you lose visualization of where you're inserting the probe, then you also effectively cannot measure that same airway multiple times. Yeah. But yeah, it's an interesting idea. Combine bronchial thermoplasty and the pharmacological approach, but we would argue that the pharmacological approach should treat both large and smaller airways.
No. I see Helmy's got a hand up.
Oh, thank you. Sorry. Thank you. It was a lovely talk, Pete. Thank you very much. I have actually a question about, you mentioned the placebo effect.
Yes.
And I was curious, so is that specific to this surgery? And are the outcomes then just people reporting that they feel better? Is there any sort of objective measure that improves?
Yeah, so the placebo effect, I don't think it is specific to this procedure. We were viewed a trial on some of these monoclonal antibodies, or a report, and they also document potential placebo effects. It is an issue when it comes to subjective measures, and as you indicated there, it's about do I wheeze as often, those sort of things there. So yeah, there is probably a psychological aspect to it, and that's what we're changing, I think.
Yeah. Okay. Thank you. Cheers.
All right, George McColgan, and then we'll take Pete.
Hi Pete, thanks for your talk. Just a quick question. I don't know if you can hear me.
Yes, mate.
Just with the azithromycin therapy, do you think that you might run into any kind of antibiotic issues long term? Antibiotics. So I guess super.
Oh, so as in an immune response to the azithromycin? Is that what you're saying?
Resistance.
Yeah, that is antibiotic resistance, right? Yes. Yeah, good point. So I guess in terms of long-term use, that might be a concern. Side effects with azithromycin tend to be a bit of gut problems, so knocking off some of the good antibiotics. So that's slightly different to what you're proposing. It was used in a 1-year trial, and no real problems apart from the gut reactions noted. Yeah, interesting comment. I might talk more about that with some of my clinical colleagues. George, thank you.
Pete.
Yeah, thanks, Pete. It was an awesome talk. I'm also interested in the azithromycin. So, is there any idea that maybe that there is an underlying bacterial infection that could be contributing to some of this as well? Is it the antibiotic properties of it? And just as a comment, you're talking about how the ideal compound is going to decrease proliferation and also increase apoptosis. Well, incidentally, that's also what the glucocorticoids are likely to do in that situation as well.
Well, thank you for that comment. We'll talk more about that. In terms of the effects of azithromycin in let's say asthma patients, absolutely, it's probably doing a lot of that, reducing possible infections, acting through anti-inflammatory pathways. I'm not certain whether we can claim any of that at this stage is due to muscle thinning, particularly because that trial there is just a bucket full of asthmatic subjects. If we're going to trial this approach, we want to pick subjects that are phenotyped based upon their airway smooth muscle thickness, and that's who we think might be particularly responsive to this type of therapy. In terms of the culture, you probably couldn't argue that had anything to do with inhibiting a bacterial infection. In the mouse model, maybe I guess the animal houses are generally pretty clean. In the naive mouse, it'd be hard to argue that is some type of infection, or maybe the lungs aren't clean. Maybe there is some low-level effect there.
So you think maybe it's an off-target type response that you're seeing with the azithromycin?
Well,
not
in terms
antimicrobial effect.
I don't think it's an I think it's acting directly at the muscle layer. Now, I admit that my cell biology is a little bit simplified there, where you've got a scale of apoptosis versus proliferation, so I might need to go a little bit deeper with that. But I think we're really aiming for something that's specific to the muscle and also airway smooth muscle. So that's the other question we haven't chatted about, is why is it knocking down airway smooth muscle? Is it going to be hurting some other blood vessels? But it's interesting to note that azithromycin deposits within the lung. Its lung to serum ratio is about 100, so it might be very good at knocking down muscle within the lungs specifically.
It's just gone 2 o'clock, but hopefully nobody's got to duck off to lectures or labs, Pete. So if you've got another minute, can I just ask a quick one? With the results on the bronchodilation after thermoplasty, it just struck me how variable that was. There were some individuals there that it really didn't seem to make a difference at all, and you had some that were going from the bottom of the screen to the top of the screen. Does anyone know what underlies that variability?
Yeah, I mean, that's, I guess, just what we're hoping to achieve with PSOCT. So let's say you have one individual that has just a lot of remodeling, and then you knock down their muscle. They're probably going to get a lot of benefit from that approach. So I think there's a lot of interpatient variation in terms of remodeling, and we would hypothesize that it's probably based upon the amount of muscle that determines whether they have a big improvement or a small improvement. Yeah,
so not how effective per se is the burning, but how much is there in the first place.
That's also an interesting point. Is for the non-responders, David has actually thought about, okay, maybe for some reason we didn't burn it all away, so let's go back in and try again. So that has been argued. You're the thermophysiologist, so I guess if you've got a bigger area, is it possible that the same temperature might affect the tissue bigger if you've got a bigger heat sink, I guess?
Does the probe actually measure temperature, or is it just put in a given amount of energy?
It's radio frequency, a given amount of energy, but there must be some feedback system there that controls the final temperature.
Yeah. Right. Yeah. No, really interesting stuff. No, it doesn't look like anybody else has got their hands up there, Pete. So thank you you've certainly given me a few things to think about, and we'll chat some more. Everybody else, please click the little thing that makes the clap go off, and we can all tell Pete how much we've appreciated the last hour. Good on you, Pete. Thanks very much.